more purpose-driven activity, decreased need for sleep, right? I'm gonna drive to Vegas and I'm gonna win a bunch of money playing, playing blackjack, and then I'm gonna write a book and I'm gonna do all these other things and everything's gonna be amazing and it's gonna be awesome and everything's great, and, right? All of that. Anybody seen the show Ozark? So the brother, right? It's actually a really good depiction of what happens, right? He goes off of his medication and he slowly starts to get zanier and zanier and crazier and crazier. That's kind of what happens. So common misconception, right? Bipolar, right? Your emotions flip on a dime. That's actually not. It's over the course of long periods of time. So what's going on during the manic phase as far as what's going on in the synapses here? Is the brain producing too much or not enough when you're in a manic phase? Too much, right? So you're overproducing serotonin, dopamine, all that. You're overstimulating the brain, right? And then what eventually happens over the course of several weeks or months? You're producing dopamine and serotonin at a rate the brain can't cope with, and what starts happening? You start to go into a depressive state because now you're not producing, you don't have enough left anymore.
Can you get circadian syndrome just from having the bipolar disorder, or you know?
Yeah, similar kind of, yeah. So you'll see like a really bad manic phase, like strung out, kind of shaky. Yeah, well, so the lithium, among other things, helps stabilize, right? So with mood stabilization disorders, we put you on mood stabilizers, right? We put you on drugs that prevent you from cycling, right? More so than some of the other mental health disorders, bipolar people tend to be more prone to engaging in illicit drug use, because what are they trying to do? Trying to bounce it, right? So they're manic and zany, right? What do? Depressants like pot and alcohol to try and chill out, right? And then they become really depressed, and what will they do? Cocaine, ecstasy, methamphetamine, all of that to try and get the brain to up. So, not the first time you're manic. The first time you're manic, you're like, this is awesome. Right? Does anybody know somebody that's had a manic episode? Yeah. So at first it seems like a lot of fun, and then next thing you know, like you've made some really, really bad decisions, and like your life's in a downward spiral. So, but the first time you have a manic episode, it's really great. So, right, a lot of that is so a lot of the drugs any drug that is altering your brain chemistry is usually altering your brain chemistry by tweaking stuff here, right? It's either producing more or less, or mimicking, or blocking receptors, or enhancing receptors. Right? So we're getting better and better at that with time.
Where does BPD fall into that? Because I know a lot of times
There's a lot of people who are BPD actually get diagnosed as bipolar. So BPD is, first off, does everybody know what BPD is? So BPD is borderline personality disorder. Do you guys know who the classic example of BPD we use in psychiatry to demonstrate the symptoms of borderline personality disorder are? So the classic example we use in cinema and TV is Anakin Skywalker. Right? So what are the symptoms of borderline personality disorder? Yeah, feelings of abandonment, right? So like there's a classic book that we give to people that are like dealing with something with borderline personality disorder. It's how to like live with a loved one who's got borderline personality disorder. The name of the book is I Hate You, Don't Leave Me. Right, so that pretty much classically sums up like borderline personality disorder behavior. BPD and a lot of the other like personality disorders, like they're poorly understood. Like we don't understand like what causes people to have them. So every one of you knows somebody that's got BPD. So like pick the friend, family member, loved one whose life is always a hot mess, and they always manage to find a way to screw up their life. That's probably the person that's got BPD, right? So like your cousin that's found the love of their life for the 5th time this year, right? And set their ex-boyfriend's clothes on fire. Like that's probably the BPD person. next day they're like,
Say that to them.
yeah, they're
And
sobbing
then
and
apologize,
crying, yeah, I'm
like,
so
send them,
sorry,
like,
please don't.
cupcakes and flowers and be like,
Please don't stop being my friend,
Yeah.
I don't blame you for hating me, I'm a terrible human being, you know. So they alternate between, like, I hate you, I'm gonna ruin your life.
Bad luck.
Please don't hate me, you're my only friend. So it's important. But anyway, so a lot of the neurological and psychiatric stuff is dealing with, those receptors, okay? So excitatory is anything that's going to make it easier for you to meet threshold. Inhibitory is gonna be anything that makes it harder to meet threshold. Okay? And we constantly upregulate and downregulate these things within the nervous system. Okay? We got a whole bunch of different types of neurotransmitters. We've identified more than 50 at this point. So we've got a whole bunch of different ones. We got serotonin, dopamine, gabapentin, acetylcholine, epinephrine, norepinephrine. You don't need to know any of them. None of them are going to be in there, but that's basically how they all work. And then we got the enzymes, which rapidly decompose them because we don't want them doing stuff too long a period of time. But again, sometimes those enzymes work too well. That's where like selective SSRIs work, right? So SSRIs are very effective. And this is also where like things can get tricky with, more so than probably any other field of medicine, psychiatry is the one that has the most complications. Right? So what happens when what are some of the negative side effects of SSRIs? Weight gain, can't do drugs, alterations in sex drive. It can cause the opposite effect, right? So it can cause you to become kind of manic if you're on the wrong one, and actually increase your risk of suicide if you're on the wrong one. So it's, psychiatry more than any other field is
mental health.
really hard.
Like depending on the person, they might have too much energy versus not enough energy, or that's too much.
Sure. Well, the problem with psychiatry is a lot of stuff we don't have tests for, right? So like a lot of fields of medicine, right, we can do a test of, like you've got PCOS or you've got this disorder, that disorder, right? There's actual biomarkers we can test. We don't have a way to do that yet with the brain, right? So like, for example, the symptoms between BPD and bipolar are very similar, right? So, you might be diagnosing somebody with BPD when they actually have bipolar or vice versa, right? So if and this is, psychiatry is really difficult, right? So you could have take the same person to 20 different psychiatrists, and you might get 5 different diagnoses, and not necessarily, it's not that any one of them's particularly wrong, right? So, I'll get a new client and I'll diagnose them something different than somebody else diagnosed them with. Based off of the symptoms, I interpret it as something different. On the person. That's the really hard part, So they don't tell you everything right off the bat. So I'll be, working with somebody for like 6 months or 8 months, and like, I think I can't understand we're making progress, and then, my stepdad tried to kill me when I was 15. That might have been helpful information. Like, if you told me that, 6 months ago, we doing things completely differently. So it's a there's a reason why psychiatrists get paid a lot of money, because it's a tough field to do. So, all right. So we also have these things called neuronal pools. Nerves and receptors and all of that kind of pull together to do kind of common functions. Pools receive input from afferent nerves, process the information according to the special characteristics of the pool. So for example, right, we got areas that specifically do like sound, smell, proprioception, etc. Right? So areas kind of specialize in doing things. That's basically what pools are. Okay? The neuron becomes more excitable to incoming stimulation. We call that facilitation, right? So that's what things like certain types of classes of neurological drugs do. They can cause facilitation. Okay? We have convergence, and then we also have divergence. So convergence is where a single neuron within a pole may receive impulses from 2 or more fibers. This is, for example, like you've got multiple trauma, right? So you've broken, right, get a car accident, you've broken 3 different bones in your body, right? All of that information from the different trauma centers is all being sent to the pain center in your brain. That would be convergence, okay? Divergence would be like, so I'm about ready to do a complex motor task like throw a baseball, right? So you got a place in the brain called the motor cortex. From the motor cortex, you're gonna send out signals to multiple different muscles in the body to synchronize so that they throw the baseball, right? So that would be, so convergence is afferent coming in, and divergence is efferent motor responses going out. So that's what's going on. And then, you had those divergent movies back in the day. So, I never understood why being divergent was a threat to the system, but being factionalist just meant you were like a sad hobo. Like, really, what was the difference between being divergent and factionalist? Like, that was like a pretty good plot line. So, the only thing I learned from that show, from those movies, is once again that Rose from Titanic is evil. I mean, she definitely killed Jack. So, they scientifically proved that Jack could have survived. Jack could have fit on there, but no, like.
You know, something that she pushed her in the water.
Yeah. She's like, yeah, there's no room, Jack. Like, yeah. Yeah. I'll never forget you, but you need to. Yeah. We hooked up in the car. I'm embarrassed about it, so you just need to just go away. Right? Okay. Types of nerves. Okay, so there are going to be 3 different types of nerves. So you can have one that's purely sensory, like for example, the ocular nerve. Right? So the optic nerve. So the optic nerve is purely sensory. Right now you can see me because there's a constant stream of photons hitting your receptors in your eye, and then that's sending signals to the visual center in the back of your brain, and that is me. You can have purely motor, like the ocular motor, which allows you to track an object in your field of vision. And then you can have mixed, like for example, the trigeminal nerve, which is involved in speech and taste. Okay? So some are purely sensory, some are purely motor, many are both. Okay? So sensory, motor, or mixed. And then we also have what are called reflex arcs. Okay? So reflex arcs are reflexes. So certain things are so vital to survival that we have a system built into the spinal cord, so we can bypass. I mean, the signal goes to the brain, but we have a built-in system going into the spinal cord. So reflex arc includes a sensory receptor, sensory neuron, interneuron in the spinal cord, motor neuron, and effector. What the hell does any of that mean? All right. So reflexes are automatic, subconscious. Right? We don't have any control over them. So here's a good example of the knee flex reaction, right? Or knee jerk reaction. Right? Go see the doctor and they check your patellar reflex. Inside your quadricep muscles, you have what are called proprioceptors. Proprioceptors detect rapid changes in the length of your muscles, right? So you hit somebody on the patellar tendon, causes a rapid stretch of the quadricep muscles. That sends a signal that hits the spine. Spine here's warning, we're about to tear our quadricep, so what does it do? Sends an automatic reflex to that same quadricep muscle to tell it to contract, so you kick your knee out. Right, so it's an automatic built-in thing.
So it goes to the brain, but it kind of splits off.
It goes to the brain after the reflex already happened, right? So
quick.
Right, so you accidentally touch something burning, right? You don't even have to consciously, right? You've already taken your hand off of it before you're consciously aware of the fact that you burnt your hand, right? And you go, ow, and then you're like, burn my hand, right? So reflexes are built into the spinal cord to speed up them happening before, right? Because that extra couple of half a milliseconds to get to the brain means more tissue damage is potentially happening. Okay, so we got all sorts of reflexes built in. So we got the patellar reflex. We also have what's called the withdrawal reflex. Anybody familiar with the withdrawal reflex? Right, so like if your arm were broken, right, you come into the emergency room and your arm's broken and they go to grab your arm, what are you gonna do? Pull away. Okay, so that's an automatic reflex. You have a flashlight in your eye, right, your pupils are going to instantly close, right? So those are all built-in reflexes.
And those could be obviously or non-police as well. That's why
That's part of why we do them and when we do field sobriety tests. And also, to this day, we still do them, right? These are low-tech neurological evaluations we can do, right? So concussion protocol, one of the first, right? So, right, you got a football player, right, and they crack their skull pretty good, and we suspect that they might have concussion. We're gonna take them into a tent, we're gonna do a protocol, or, concussion protocol. One of the first things we're gonna do is we're gonna shine a flashlight, headlight in their eye. What's an abnormal pupillary response to a flashlight in your eye? Your eye's not, your diameter not restricted. Right? So somebody that's got a bad concussion, right? Same thing like a field sobriety test, right? You're coming back from Apache Junction and you inhale a little too much methamphetamine in the air and you get pulled over, right? Cop pulls you over, shines a pen light in your eye. Somebody's high as a kite on methamphetamines, what's gonna happen? Right? Their pupils are gonna be sized as saucers, shining a light in their eyes, not going to change. So we can do this for drug and alcohol, but we can also do it for neurological. So if you have something neurologically abnormally wrong with you, you will have a negative test. So for example, one of the tests is called the Babinski reflex, right? So in the foot, right? So a normal Babinski reflex, right? So when a child or an adult, right? We take something and we put it on the inside of your arch. What are your feet gonna do? They're gonna curl, right? What's a baby gonna do? Gonna go out. Baby, a newborn's feet will go out. An abnormal Babinski response in an adult would be also for your feet to go out, right? So somebody that's had like neurological trauma, right? We do a Babinski test and their feet go out, that would indicate that there's something going on neurologically, right? Or they don't do the patellar reflex or some of the other reflexive responses, right? So this is why, like, you go get a physical, right? And they do some of these pupillary, they're doing a low-tech neurological exam to see like if you're having an abnormal reflexive response. If you don't have one, doctor's going to assume neurologically you're doing okay. You have an abnormal neurological response, and they're going to say you need to go see a neurologist. That would indicate that something abnormal is going on. So yeah, so so field sobriety test. What are we doing in a field sobriety test? We're testing different levels of like neurological impairment, right? So first thing first, right? You had anything to drink today, right? Shine a flashlight in your eye, eyes don't dilate. That right there is enough that we think that you're right. Your eyes are like saucers; they don't respond at all to light, right? No, I haven't had anything, right? Stand up, right? Right. So it's just different kinds of things. Right?
So screwed.
Yeah. What should you do if they want to do a field sobriety test, guys, and they want you to blow the breathalyzer?
Just say no.
Say I want to wait until my lawyer and the supervisor is present, because they have to do that, right? So by the time like everybody's there to show up to give you the breathalyzer, you might be.
If you don't have a lawyer.
Unless you're really feeling bad.
Yeah. 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 So wait and say I want to wait for a lawyer and supervisor to show up.
Will they provide a lawyer?
Huh?
They'll still arrest you, right?
Well, they can detain you until like your lawyer shows up to supervise you doing the breathalyzer test, which in theory by then you might be sober and I don't think you passed the sobriety test.
It can actually be worse too, because sometimes your blood alcohol will
Go up.
take blood tests instead.
Yeah.
Will they provide a lawyer?
You can.
Not very good.
Not a very good one, but
Civil.
but if it takes 3 hours for a lawyer to show up, you might be. Or you could just not drink and drive. There's that as well. I had a student one semester, like we were having this lecture about drugs, and like he was asking, like, are certain drugs like worse for you than others? I'm like, well, meth and ecstasy are probably the two worst drugs you can do from a brain health standpoint. Like ecstasy is really bad for your brain.
Is that ecstasy or MDMA?
Both.
Isn't that the same thing?
Yeah.
Because ecstasy is usually with MDMA,
Yeah. Cocaine, yeah. So yeah, they're both like they're really bad for your brain, and if you're not doing a medically a medical dose, right? So like we actually now use MDMA, acid, and other kinds of things. There's actually proof that it can actually like reduce symptoms of psychosis, depression, all sorts of other things, right? So we've and medically appropriate dosages done under supervision of a psychiatrist, right? We've actually had people they have what they describe as a religious experience, right? They stop being depressed, stop being drug addicts, things like that. But in recreational doses, it can cause real serious, sometimes long-term permanent damage to the brain, right? So I don't want to be like Mr. Mackey from from South Park, but really stay away from methamphetamine, stay away from like MDMA. Yeah. Yeah, a lot of rape people have long-term psychological, psychiatric problems, and they're like hardcore rapers, so stay away from those, Lorraine.
Okay, will do.
Yeah, ketamine works on the same kind of level, just not quite as well, so MDMA just recently kind of started like making it, and same thing with like, yeah, ayahuasca and other kinds of things like that, we're not sure how, but we think it kind of just like, again, in a medically appropriate dosage under the supervision of a psychiatrist, we found that it might actually like rewire stuff and like kind of get your brain right. So you could do, sometimes we have we don't really do a whole lot of electroshock therapy anymore, but we still do it for talk therapy, yeah, the talk therapy. Yeah. No, we actually still do shock therapy, yeah, for very extreme cases, but it's a lot lower dosage than it used to be. No, they still have the electrodes there, but it's not like the old days, like One Flew Over the Cuckoo's Nest, where like, it's a very low dosage. But we have found that for like forms of depression that aren't responding to anything else, for reasons we still don't understand, electroshock therapy does seem to work. We're talking like people like so depressed they can't even like function, like they can't speak, they can't get out of bed, anything like that. So, psychiatry really and neurology really are told, that and genetics. They're the last frontiers of medicine. Like we just really don't understand a lot about the brain. Still don't. Yeah. It's we talk about it's the only organ that's aware of itself. So we really don't understand it very well. So yeah. But anyway, so I had a student ask me one time like the rank the drugs in like order of like how bad they are, and he's like, so would you say like cocaine's better than like ecstasy and methamphetamine? I'm like, I guess, yeah, like he kept like asking the question in different ways. Like dude, like you can ask the question as many times as you want, like I'm never gonna say it's okay for you to take cocaine. Yeah. Like I can just like see the headlines now, like MCC student ODs on cocaine after, professor tells him it's okay to take it. Yeah. But it's really odd, like he kept like coming at it from a different angle. I'm like, I'm never gonna tell you cocaine's okay for you, dude, because it's not. Yeah.
Lectures on YouTube.
Yeah. So it not being as bad for your brain as other drugs doesn't by default make it good for your brain. It's just less, yeah. So like ecstasy, methamphetamine, there's a lot of documented data to show that it can cause sometimes permanent alterations in brain function and not in a good way. Permanent psychosis, right? I've seen data of people like getting with like Tourette's-like symptoms and Parkinson's-like symptoms and stuff like that. So like people who are hardcore partiers and ravers in their 20s, by the time they get in their 30s and 40s, like their brain just does not work the way it should anymore. Yeah, so it's really bad stuff. And you can also get that with alcohol and cocaine too, just less likely to happen. All right. On that note, let's take a break right here. So we'll start off.